Good morning, everybody. How's everybody today? Thank you to all of you who've traveled from far and wide. Today, we have participants from Calcutta, from Srinagar, from Baroda, and thank you all for joining this one-of-a-kind program. So, I'm Sonal Asthana, I'm one of the course directors. This time, we have an excellent course, faculty leadership, Professor Kumar Deetal, Professor H.S. Saldana, Dr. Sandeep Atavar, so with a very big focus on heart and lung as well. This program started in 2014. It was actually a program that we developed in partnership with Oxford University in England. This is part of training in the UK to retrieve organs safely, because this was something that was part of standard training for transplantation. We saw a gap at that time because although organ retrieval was increasing, but there was a very big lack of trained surgeons who could retrieve organs safely. Not just in curricula, but even in situations where you had organ donations in, say, smaller cities, where people were not able to retrieve organs safely. So we have been supported on this program year on year by Oxford University, by the Indian Society of Organ Transplantation, by NATO, and by various other professional organizations, as well as colleagues from the industry. And we have trained more than 180 surgeons in organ retrieval. In terms of impact, I must say that our cardiac program has actually been fantastically high impact. People have actually managed to go ahead and develop transplant programs after training in this program as well. So over the next 2 days, most of you can expect to learn a little bit about not just the transplantation surgery, but also the ecosystem, because the first half of today is focused on the law, focused on what NATO does, focused on what a coordinator expects from you when you actually go for a retrieval, focused a little bit also on the webcast of how to do an organ retrieval, which will be demonstrated by very, very senior surgeons. In the second half of today, there will be organ-specific sessions, which will be one-on-one teachings on specific scenarios related to heart and lung retrieval, to kidney pancreas retrieval, as well as to liver retrieval. Tomorrow is the wet lab, where you actually will get a chance to implement all that you see and learn today and practice that on a frozen cadaver. We are obviously supported in MS Ramaya because it's the best lab of its kind in the country. You will work on cadavers that are almost lifelike. So hopefully you'll have a good learning experience. So thank you on again. To start with, we have a person who needs no introduction to people who work in transplantation, Dr. Anil Kumar, who's actually ably steered the National Organ Transplant Program for so many years. Dr. Anil, thank you so much for joining us. Can you hear us?
So fine. Good morning, everyone. So thanks, Dr. Sonal, for inviting me to give this presentation on National Organ Transplant Program and role of NATO in facilitating organ donation in India during this 7th National Organ Donation Master Class. Like definitely, it's really to be it's a privilege for me to be present here today among all the eminent surgeons who have joined this master class from all over the country. And thanks to you and thanks to the and you have been conducting this at the Advanced Learning Center of the MS Ramaiah Medical College. So thankful to the Ramaiah Medical College organization also. So I'll be just giving an overview of the National Organ Transplant Program and role of the National Organ and Tissue Transplant Organization. Basically, the structure will be the background, the institutional framework, what is the National Organ Transplant Program, and the today's agenda, that is the current policies and processes of NATO, the method of allocation of organs, registries which are maintained at NATO, and availability of the standard operative procedures and other issues. So basically, as we all know, the legal framework is as per the Transplantation of Human Organs Act, which was passed in 1994 and further amended in 2011 when tissues were added. The scope was expanded to include the tissues. Then subsequently, after the act was promulgated in 1994. Three times the rules have been issued in 1995, amended in 2008, and then revised, comprehensively revised in 2014. Basically, the objective of the act is to regulate what? Regulate the removal, storage, and transplantation of human organs and tissues for therapeutic purposes and prevention of commercial dealings. So the status is this, that this act, the original act 1994, is adopted in all states and union territories except the Andhra and Andhra Pradesh and Jammu and Kashmir, when Jammu and Kashmir was a state. And right now, the amended 2000 amended act, that is the amended after 2011 amendment, it is applicable in all states except the eight states which have not yet adopted the amendment act. And one of the state is Karnataka also. And we have Andhra Pradesh, Telangana, Arunachal Pradesh, Meghalaya, Mizoram, and Uttarakhand. These are the 8 states which have not yet adopted the Amendment Act 2011. So, so what is the current landscape? If we look at the landscape of organ donation and transplantation in our country, as per 2019, the India holds the third place in total number of transplants after USA and China. And we definitely, the number of transplants has increased roughly from 5,000 in 2013 to 12,666 in 2019. And so there was a 2.5 times increase in these 6 years. And but still, the living donor transplants are the major transplants which are done in the country. So, like, these are the numbers of 2019, the living 10,604, out of which 9,751 kidneys and 2,592 liver transplants and 187 heart transplant. 2019 data, why I'm quoting this is pre-COVID, 114 lungs and 22 pancreas. So, and out of the total transplants in 2019, deceased were 2,060 and domino were 2 transplants. So, so you can see there is a huge shortage against the requirement. Requirements are also shown in this slide. So, and regarding the cornea transplants, we are able to meet around 50% of the annual requirement of 1 lakh. So now the country is having the capacity for undertaking rare transplants in some of the centers like pancreas, intestine, hands, limbs, lung, and uterus have also been done in the country. Definitely during the pandemic time, there has been a decrease in both organ donation as well as transplantation, but we are now surging back. So donation after cardiac death is also being undertaken in 1 or 2 institutions. And but as we all know that usually the organ donation, when we say, it is after brainstem death. The donation rate, that is the number of deceased donors per million population, which is used for international comparisons, it has increased. Like, it was roughly 0.27 in the year 2013 in India, and it reached to the peak of 0.65 in 2018. But still it continues to be less than 1. And in 2019, roughly 529 hospitals which were undertaking transplantation or retrieval, they were linked with the NOTO for the national network. And as per the 2019, the Tamil Nadu and Maharashtra, they were contributing maximum number of organ transplants. So what are the various institutional framework which are available? Under the law, we have appropriate authority. Appropriate authority is 1 or 2 or more than 1 officer which is appointed by the state government. And mainly the appropriate authority, the functions are to grant or renew or suspend or cancel the licenses for transplant. No hospital can undertake any activity whether related to retrieval, transplantation, or tissue banking without the license or the registration certificate from the appropriate authority. So they have all these powers. They also have powers to enforce the standards. They have powers to investigate complaints. In fact, they have powers of the civil code. They can summon the hospital, their staff, and they can carry out inspections after giving notice. So all these powers are there with the appropriate authority. So that is one institution which is the appointed by the concerned state government. So this is a state government institution. Then second, we have a national human organ and tissue removal and storage network. The network is like provided under the 2011 Amendment Act. So this network basically right now has one national organization, that is NOTO at Delhi. Then it has got 5 regional organizations, and right now 16 state level organizations, and few more are coming in pipeline, and 638 hospitals are also part of this network right now, which are transplant or retrieval or tissue banks. So then third framework is the registry. So it is a registry which is of the donors and the recipients of the organ and tissue transplants, and this registry is mandated to be maintained by the central government as per the act. So then another framework or the institution is the program. This program is there since 2013. Basically, the objective of the program is to organize an efficient system of procurement and distribution of the organs from the retrieval to the transplantation, create infrastructure for retrieval, transplantation, and strengthen the existing units, and to carry out awareness, basically, and capacity building, and to establish the registry, which is mandated as per the law. So this, under the program, we have certain grants which are available. Uh, so I'll just go to the slide of the grant. These are the various grants which are provided under the organ transplant program. The grants are there for establishment of the regional organizations, of the state level organizations, uh, for their both staff as well as their infrastructure refurbishment. Then for setting up of the new retrieval center, 75 lakh rupees. For setting up of a new transplant center, 1.5 crore rupees. For upgradation of the existing retrieval or transplant unit, 75 lakh rupees. Then for hiring of the transplant coordinators, so it is 35,000 per month per transplant coordinator. So government institution, they can take 2 transplant coordinators. Then private centers, they can take even good performing private centers. They are also supported with 1 transplant coordinator under the program. Then trauma centers, 1 transplant coordinator. Then for biomaterial center, basically for regional level, we are like promoting tissue banks. So these are 1 crore rupees is available for the biomaterial center, and immunosuppressant therapy for BPL transplant recipients in the government institution. So those transplant patients who are BPL category, they are given under the program rupees 10,000 per month till the immunosuppressant therapy is required after the transplant. Then another provision has been made under the organ program is the dignified funeral of the deceased donor. So this is for any donor, whether in government or private, whether APL or BPL. So it is 10,000 rupees per deceased person. So deceased donor, basically for the purpose of dignified funeral. So this, the SOTO has to decide how they want to spend it, whether they want to give it cash or they want to give it in some kind of a arrangements for the funeral. Then maintenance of the bodies of the deceased donor. Basically, this is for the hospitals where the retrieval takes place. When one organ is given to a government institution after allocation and is utilized, then up to 1 lakh rupees per donation can be given as reimbursement for the maintenance of the body of the deceased donor. So these are the various grants which are available under the organ transplant program. Uh, just a moment. So then coming to the status of the program, if we basically, that's what I'm trying to show here in this slide, that we have organizations, but the uptake of the grant by the states or regions is quite low. That is one issue that we are facing. We are giving them grants, but their utilization has been low. Then, so uptake is inadequate. Need for constant hand holding by the NOTO is there. We don't have regular central government staff in these institutions, that like region and the regional and the state organizations, and staff shortages are also there. Many vacancies are there, and there are certain times delay in transfer of funds. So those issues are there, which are administrative issues, and so that we are dealing with under the program basically. Uh, Coming to the next, so these are the network that I was talking about. So 5 regional organizations are located at Chandigarh, Guwahati, Chennai, Mumbai, and Kolkata. Then we have 16 state level, like states are Uttar Pradesh, Rajasthan, Haryana, Jammu Kashmir, Punjab, Himachal Pradesh, Kerala, Andhra, Puducherry, Madhya Pradesh, Goa, Gujarat, Dadar and Nagar Haveli, Bihar, Jharkhand, Odisha. And the for Karnataka also it has been approved, and we are going to release the grant maybe within a week. So that is also there. So we have around 600 38 hospitals which are linked with this. But when we surveyed that, around 187 are totally non-functional. They are registered as retrieval or transplant hospital, but not even one transplant or retrieval activity has taken place in these hospitals in last, I think, 2 to 3 years. So that survey was carried out. Now, what are the main mandates of the NOTO? The NOTO main mandates are policies, SOPs, and guidelines. Basically, beyond the Act, whatever policies or within the framework of the Act and the rules, the policies and state standard operating procedures and the guidelines which are to be issued, they are issued by the NOTO. Then to create this national networking and registry, with the purpose is for efficient procurement and distribution of the organ and tissues, to promote the deceased organ and tissue donation and capacity building, trainings, organizing such kind of training. So this is the state-wise distribution of the centers which are registered with NOTO. So right now, centers from 27 states and union territories are linked with the NOTO network, and the maximum registration you can see are from Maharashtra and Tamil Nadu, and then there are other states also. So these are 638 hospitals which are linked with the NOTO network right now. So, and the distribution state-wise and UT-wise is given in this graph. So what are the so as we talked about the basically what are the current policies on national registry? So in the national registry we have basically organ transplant registry. The transplant registry basically has 3 parts: pre-transplant demographic details of the recipient. When the recipient is registered, then it has got the transplant details and the post-transplant follow. So these 3 components are there in the transplant registry. Then organ donation registry, that includes the data of the donor, both living as well as deceased donor. And then tissue registry, and the 4th registry is the pledge registry, the people who are pledging for organ donation after their death. So then we have various policies on allocation of the organs. So the major points I will be telling you, that recipient is to be registered at one of the hospital. All these hospitals which are part of the network, they are given login ID and password by the NOTO, and the hospital can register its patient on its own. Noto is not required to register it. The hospital has been given the authority to register their patient, and their data will be then included in the Noto registry, and and those who even who are waiting for living donor transplant, they can also be registered for deceased donor transplant. So, and the status of recipient must be updated regularly. Then there are various allocation criteria for deceased donor transplants, which have been prescribed by Noto for kidney, liver, heart, and heart lung. They are available, but basically these are available on the Noto website. I will not go into the details, like what are the various criterias, because we are not going to discuss, because it will take a lot of time otherwise. So, so there are basically the allocation criterias have been defined. They are available on the Noto web portal, noto.gov.in. So coming to, yeah. So how, what is the policy on procurement and distribution of organs? Like, first we have to basically, there is a, first the allocation is done at the local facility level or the hospital level. So for this basically includes checking for the recipient availability. When the call is received by the SOTO or the call center that a donor is available, or right now it is, as you all may be aware, that it is being done through a WhatsApp group, and the alert is received by the in the WhatsApp group that a donor is available in a particular hospital, and then a check for a recipient availability is undertaken first at the local facility level. And as per the policy, one kidney at least has to be shared, and other organs which are not for which the hospital is not authorized or doesn't have the facilities, then those organs will also be shared by the hospital, the donor hospital, and they will be allocated through the allocation using the allocation policies. And though allocation policies can be state specific, that is allowed under the rule. So first is at the local level. If not utilized, then at the state level. Then if not utilized, then it is given the organ goes to the regional level. There are regions have been defined, and that in the region where it will go, it will be decided by the ROTO. In the state where it will go, it is decided by the SOTO, and at the national level, it is decided by the NOTO. If the organ cannot be utilized in a region also, then it will go to the national level, that is by the NOTO. And the person, then if no Indian taker is there for an organ, then this organ can be allocated to a person of Indian origin, or if no person of Indian origin is also there, then it can be given to a foreigner also. So this is the general policy how the organ allocation is to be done. So then coming to the so this is the then availability of the various SOPs. So these are the various SOPs which are available. They are available on the website of the NOTO. Basically, the how the eye retrieval is to be done, for preparation and conduct of the donor heart retrieval. Similarly, maintenance protocols, etc. All these SOPs are available on the NOTO website, and by visiting the website, one can go through all these SOPs. So, just a moment. Yeah, what is the method of allocation currently being followed? As I told you, that call for allocation comes directly to from the hospital to the SOTO. Then it will there is basically a SOTO level, state level group is there, and NOTO is also a SOTO for Delhi. So NOTO is maintaining two groups. One is for the state of Delhi, and one a national level group. So whenever the organ is not basically cannot be allocated at regional level, then it comes to NOTO. So these calls are made by telecounselors and also by the transplant coordinators. And currently, though there are issues in the allocation in the such, but it is still quite transparent, because all the stakeholders are there in those groups where even all the detailed reports are shared. But we want the automation to be developed in the registry so that nobody can question. Though WhatsApp groups communications will still be required to take care of the finer aspects, like sometimes there is a demand for the report of the like echo, sometimes there is a demand for the report of the particular CT scan. So those things the recipient hospital wants to have a look at. So before deciding to go for accepting the organ which is being allocated so to them. So then various other issues which we are facing, that all the states they need to adopt this act, and so that the national network is complete and registry is complete. All the hospitals they have to board their data onto the noto registry. We require dedicated transplant units, particularly in the related departments of the hospital. There is an issue of uniform declaration of death, that is itself is a very big topic. We also require to augment the staff and various SOPs related to the box transportation of the human organs and tissues, which are being now being refined by the NOTO in, and the Niti Aayog is also helping us in this, and in developing a organ transport policy. So having the trained transplant coordinators and the grief counselors are also very important for the success of the program. We are also looking at developing all AIMS as center of excellence for organ and tissue transplant, with also having the lab facility for HLA as well as tissue banking facilities. So then we are also working on the IT solutions in coordination with the National Health Authority. Also, we have to take care of the basically the cost of the HLA and other lab tests which need to be capped, and which are sometimes many times mandatory for organ and tissue transplantation. So that also we are working upon. So then. So this I've covered. Just a moment. Yeah, one or two slide more. So various challenges, we are having a demand that stem cell transplantation and bone marrow transplantation should also be included under the scope of TOTA. So that is there. Then we are also thinking of professional transporters for transportation of the organ. There is a talk going on regarding the drone also. Then way forward would be to capacity building needs to be emphasized. This training of retrieval surgeon, which is being done in simulation labs or in retrieval OTs, this is a way forward. One of the important activity for augmenting the skills. Then for immunosuppressants, we are also now asking the states to give medicines directly to the patient instead of the grant if it is possible. Then infrastructure upgradation and transplant units, dedicated transplant units, particularly in medical colleges, training institutions, so as to improve the availability of skilled staff, that is particularly the surgeons, shortage is there everywhere. Then provision of the grants to the transplant recipients in the government hospital on the basis of the BPL cards, that has to be like augmented. Then training of transplant coordinators and a live dashboard with dynamic content to be made functional on the Noto web portal, and mechanisms which are required to ensure registration of all needy patients. Because sometimes what we see that all the patients who require transplants are not getting registered, and we receive last minute requests. So hospitals should not pick and choose patients. If any patient who requires transplant, they should be included in the waiting list. They should be registered with the in the Noto registry, so that they are there on the waiting list. Because many times we have received last minute requests that this patient has been receiving treatment for last 4 or 5 years, but he was not on the waiting list. and they want then organ to be allocated to that patient. So it is just a laxity on the part of the hospital. Hospital should not pick and choose. They should register all their patients who require the organ for transplant. For uh, so yeah, just a just. So I think this was the last slide. Uh, yeah, just a moment. Yes, thank you.
Thank you, sir, for that very comprehensive cover, and I think that it's a revelation to all of us to see the extent of the work that is being planned. I'm very sure we'll be able to implement it shortly as well. I think we are doing the last part of what you mentioned, the training, the skills development. We are a
If
little
there are any
late,
questions,
but
I'll take up.
perhaps a couple of questions if somebody has any questions for Dr. Anil.
Stop.
So, I mean, Dr. Anil, do you have any reason why we do not have uptake by states from all the funds that have been released? Because
Actually,
is the
your
process too
voice is very,
cumbersome, or what is
it's
the
not
main reason?
audible. आवाज तेज करना चाहिए.
Can you hear me?
Yeah, it's very low.
Yeah. No,
Yeah,
I said,
yeah, yeah, yeah.
do you have any reason why states have not used all the money that has been allocated to them? Is the process for utilization too cumbersome?
It's not audible. Can we have this?
Okay.
Yeah, now a little bit.
Yeah. No, do you have any reason why states have not utilized the money that you've set aside for them?
Uh, Basically, we insist that they should have dedicated staff, and we have provided budget for that also. But somehow, what we observed that they have not hired the dedicated staff because this is a work. They think that it's not. Matlab, if the existing staff they try to do this work, then they will definitely short of time, and because they have their own engagements. That's why they have neither hired the staff, they have not still then the activities which were expected they have not been done. So that is the main reason. The grants have been given, the guidelines have been given, but that is one concern that they should be as you know, this organ donation and transplantation, it's the people who are passionate about this subject, they basically push the program, and so institution they should identify the passionate people and involve them in like pushing this. Some of them are doing good, but some of them are not doing good.
Thank you so much. We really appreciate your presence with us here today, sir. Thank you so much.
Yeah. Yeah. Okay.
I'm
Thank
signing
you.
out now, sir. Yeah. Well, that was Dr. Anil Kumar, perhaps giving you an overview of what the national program is like. But the reality is that we all know that the program runs in states, really. And one of the big differences that the South and the West, which actually had good programs, are now struggling to fit into, sort of a protocol that has been developed currently for states that are, in a different process of their evolution. So certainly this is work in progress. We do need a national policy, and as you've seen, there are obviously a lot of solutions to the many challenges that we have. The next talk today is perhaps a talk that's very, very important for all of us, the Transplantation of Human Organs and Tissues Act. Do you know what is the difference between a retrieval surgeon and a normal surgeon? A retrieval surgeon can go to jail for doing his job, right? Until you've actually specified and worked according to the laws of the land, until you're sure that the patient is brain dead, you're retrieving it in a particular process, you risk the full weight of the law coming down on you. So it's important, for us it's a requirement to know about the law in detail. And today to talk about the law is none other than Professor O.V. Nandimath from our own National Law School, we are blessed to have one of the foremost experts on this law with us here today. He's actually been lecturing on this topic for the last 8 years. We've been working very closely together, and he's very recently written a chapter on a book on the Human Organs Transplantation Act, along with Professor Harsha Johri. Professor Nandimat, thank you so much for joining us.